So, the subtle art of understanding urine output. These are the conflicts of interest I should disclose. I really think that in the context of critically ill intensive care units and even operating rooms, urine output should be considered a vital clinical sign. And the assessment and monitoring of urine output is something that we pay attention to several times during the day. And when we observe a reduction of urine output, this is which is a quite frequent problem, both in critically ill and perioperative patients, we normally react, as some friends of mine and previous speakers were used to say before, with a monosynaptic reflex. In this occasion, we normally go for a bolus of furosemide, and magically we will see urine output normally going up, and we are happy. Also thinking that with this action, we are going to improve renal function and even maybe circulatory shock. Then of course this is not the case. But how can we better study this phenomenon, the reduction of urine output, especially in critically ill patients? Now, one of the key points is to find the proper control group. And these investigators decided to compare urine output of junior doctors with that of patients they were taking care of. This is the perfectly matched control group. So in 87 shifts, the investigators observed 22% of cases of AKI, risk of AKI in junior doctors, and even 1% of injury. So much so that doctors were more likely to be oliguric than their patients. And at the end, the investigators concluded that managing our own fluid balance is more difficult than managing it in our patients, and we should drink more water. Now, besides this joke, it's true that urine output and renal function is one of the three most important windows, as Jean-Louis Vincent used to teach us, leading us in proper information on tissue perfusion, especially during a state of shock. And urine output is a key indicator of intravascular volume status. So much so that even in the definition of AKI, urine output has been introduced, especially in the definition of the severity of AKI, also in association with the duration of a reduction of urine output, as well as serum creatinine. Now, in order to, I think, deal with this topic, we need to remember some physiological concepts of renal circulation. First of all, we need to keep in mind that renal circulation starts and originates quite soon from the systemic circulation. So much so, renal circulation is tightly linked to the systemic circulation. And this is why renal circulation is extremely sensitive to every single variation of systemic circulation. And we know that renal circulation is able to maintain constant renal blood flow and even GFR within a wide range of mean arterial pressure, between more or less 60, 65 and up to 170, renal blood flow remain constant due to a progressive increase in vascular resistance of the afferent arteriole. And indeed, we need also to remember that renal circulation normally receives 20% of cardiac output and is very active in vasoregulation, so much so that normally, in normal conditions, it works 100% vasodilated. And this is why every time we have a slight reduction in mean arterial pressure, we always see very soon a reduction in urine output, because normally it works 100 vasodilated. And we need also to keep in mind that normally a renal system consumes a low amount of oxygen. Although there are some heterogeneities between cortex and medulla, normally medulla is more sensitive to ischemic injury as opposed to the cortex. All of these are the basis to consider diuresis as a very sensitive marker of a reduction of the effective circulating blood volume, and persistent oliguria may be therefore a sign of a reduction in GFR or creatinine clearance, and therefore a sign of renal dysfunction. However, we need also to keep in mind that physiologically, the renal system has also a quite powerful system which gives renal system the possibility to vary and to modify the total amount of urine or water excreted in order to cope with the maintenance of plasma osmolality. The renal system physiologically is able to reduce urine output down to 400 ml per day, which is the minimal obligatory amount to excrete daily catabolic products, and up to 10 to 20 liters per day, physiologically. This is a very powerful and adaptive system that the renal system physiologically has. And in order to give you an idea of how nature is really smart and fascinating with this point, look at this article in which some investigators decided to describe water balance in camel in the desert. Back in 1956, after setting up a research lab in an oasis, Benia Bay in Algeria, in the middle of Sahara Desert, these investigators decided to include 26 camels and 1 donkey as a control group. And in a subgroup of a couple of very happy camels, they also were able to monitor on a daily basis body weight. They took feces, samples of feces and urine, and they controlled diet. And look at the time course of urine output of this very happy camel, which was not able to drink water for 16 days without any sign of dehydration. As you can see, urine output dropped down from 7 liters a day, which is the physiologically urine output, down to 500 ml per day. And after 16 days, the investigators allowed it to drink again water, about 40 liters. And urine output was restored. And you can also appreciate that urine osmolality paralleled, on the other way around, the reduction of urine output. Now, if we apply the normal threshold of urine output we apply in human, this could be, I think, the first case of camel AKI. Then, of course, this is not the case. So, at the end, what is the main problem? We know that oliguria is frequently the first indicator, maybe the first indicator of acute renal dysfunction. But every time we see a reduction of diuresis, we know that this is linked to a reduction of the effective circulating blood volume, but it's like to be in front of a black box. We are blinded on the mechanisms behind this reduction, and we don't know whether this is a physiological response or a pathological response. So should we use urine output as a target of our therapy? Now, to deal with this question, I think we need to keep in mind at least 4 important considerations. The first one, which is the normal value, and which normal value of urine output should we target? Is 0.5 ml per kilo per hour the normal threshold value, as we are used to know? But at the same time, physiologically, we know that the minimal normal value could be down to 0.2 ml per kilo per hour. Now, this issue has been studied in several investigations in the last decade. This is one of the first one, in which the group of Talmor analyzed retrospectively more than 70,000 critically ill patients, investigating the relationship between urine output, creatinine, serum creatinine, in hospital mortality, and renal replacement therapy. And from these contour plots, you can appreciate that when we apply the normal threshold value of 0.5 ml per kilo per hour, it's true that below this value, there is a progressive increase of the risk of adjusted mortality and the need of renal replacement therapy. But it's also true that there is a gray zone in which this increase is not that clinically relevant, suggesting the possibility of lowering the normal value down to 0.2, 0.3. And actually, this hypothesis has been somehow proved in another recent publication, published this year on critical care, in which always on another retrospective analysis of a large cohort of patients, more than 15,000 patients divided in a training cohort and a validational cohort, the investigators observed that below a threshold value of 0.2 ml per kilo per hour over 3 to 6 hours, there was a progressive increase in the risk of adjusted mortality, suggesting that this could be the normal value to define oliguria. Renal blood flow and urine output might not be associated with GFR. Now, there are several investigations supporting this hypothesis. This is just one of the, I think, more elegant studies from the group of Bellomo, performed in an experimental sheep model of sepsis. As you can see, after the induction of sepsis, there was hypotension, of course, associated in this case with an increase in cardiac output and renal blood flow, like in a hyperdynamic state, but as opposed to a reduction of diuresis. And this discrepancy between the increase in renal blood flow and urine output was even present after the administration of a vasopressor, norepinephrine, which was able to increase mean arterial pressure, increase renal blood flow, but at the same time there was a reduction in the perfusion of the medulla and a reduction on even the consumption of oxygen at this level of the renal system, suggesting somehow a physiological shutdown of the renal system in order to deal with sepsis. Acute renal dysfunction may occur without any histopathological modification of the renal parenchyma. There are also some data on that. This is one of the first studies published in 1999 by the group of Hotchkiss, performed in 20 patients dead after septic shock and multiple organ failure. And in a post-mortem analysis, despite the fact that in the majority of them there was renal dysfunction, just in one of them there was sign of necrosis and apoptosis. And last, the clinical environment surrounding our patients, including all the therapies needed, may already affect renal function. If this is a simple representation at the cellular level of the physiological fluid balance with physiological triggers such as thirst and physiological procedures such as oral ingestion and normal renal function, think about what happens when we apply positive pressure ventilation, sedation, intravenous fluids, and intravenous salt loading, renal replacement therapy, diuretics, and even nutrition intravenously. This is a tremendous stress for our human adaptation, and it's extremely difficult for our body to cope with this stress. Just to give an example, this is a quite old study investigating the effect of just positive pressure applied to the thorax on the renal system. In 7 patients, 3 consecutive phases, 0 PEEP, 10 PEEP, and 0 PEEP, back to 0 PEEP. As you can see, there was a strong activation of renin activity, aldosterone activity, ADH, PGE, and PGF-alpha, which were responsible for an increased, for a reduction of sodium and potassium excretion, just for the application of positive pressure ventilation. So should we restore urine output pharmacologically? Wow, this is an important question. So the use of diuretics. Wow, I think we have tried many times for several years to demonstrate that the use of diuretics may somehow improve renal function and even may prevent the occurrence of AKI, but this is not the case. This is just one of the RCT performed on this topic, the SPARK trial, 70 patients randomized to receive furosemide or normal saline, no difference in renal replacement therapy need, time to renal recovery, or mortality whatsoever. And even when we think about more elegant rationales, such as, for instance, the possibility that diuretics may reduce oxygen consumption at the level of the renal system, although the issue is controversial, we don't have conclusive data supporting this hypothesis. And also when we consider diuretics as an unblocking agent, able to unblock all the tubules blocked by detriments, we don't have any clinical evidence supporting a beneficial effects on diuretics in this context. And let me just give you a further example on what I really think it's not a wise idea to use diuretics in the early phase of the resuscitative phase, because we are going to lose a wonderful monitor of the effectiveness of our resuscitation. This is a normal renal functioning with the production of 70 ml per hour of urine output. When this patient will develop shock, urine output will go down to 10 ml per hour, for instance. But if we are good in apply a proper resuscitation, in few hours we may observe an increase in urine output, maybe up to 40 ml per hour, and this may indicate somehow the recruitment of normal functioning nephrons. But the same amount of urine output could be also achieved just giving a bolus of furosemide, which will act on the just few nephrons normally functioning. So in this case, we are losing completely the powerful of observing the increase of urine output as a sign of the effectiveness of our resuscitation phase. So what could be the future trajectory of this topic? Well, as also Manu was saying at the end of his introduction, I really think that the real-time monitoring of this parameter could be a wise idea to go. This is the development of just one of the automatic devices available, for which also Manu Malbain has contributed to the development. But in my opinion, there is another important point, because here we are just dealing with the volume of water excreted. But why don't we look also inside what is present in this volume? What am I talking about? Well, the renal system physiologically, in addition to excrete a volume of water, normally is able to regulate quite finely and tightly the concentration of electrolytes inside this volume. And is doing that in order to cope with its regulatory function as a response to volume variation of the effective circulating blood volume. And if we are doing that, we may take advantages of two main aspects. First of all, the role of the renal system as an amplifier, because here we are dealing with a small amount of volume as opposed to the extracellular space. And the second one is the possibility to even be able to detect in an earlier phase possible alterations of the effective circulating blood volume. Let me just give you a simple example. Here we may have a normal macrodynamics, for instance, with 4.0 liter per minute of cardiac output, and this may be the result of a normal function of the circulatory system and a normal hemodynamics. But the same value of cardiac output could be also the results of feedback mechanisms just reacting to a transient but clinically relevant reduction of the effective circulating blood volume. But all these feedback mechanisms are responsible for a condition of avidity to sodium of the renal system. So how can we unveil such a situation and such a condition of sodium avidity of the renal system? Well, we may try to interrogate the renal system, just giving it an extra amount of sodium, for instance, associated with bicarbonate, and recording afterwards the possible excretion of sodium bicarbonate, just looking at the variation of urinary pH as a more sensitive parameter. And look at what we have observed just applying this novel device. In patients with a reduced effective circulating blood volume, there was no variation of urinary pH after the administration of the extra amount of sodium whatsoever, while in patients with normal or an increased effective circulating blood volume, we observed 10 to 20 minutes after the administration of this extra amount of sodium, a significant increase of urinary pH. So at the end, I think that this could be a proper trajectory of this topic, at least in my vision, and taking into account and applying at the bedside real-time monitoring of both volume and maybe electrolytes, and giving all this information to an artificial intelligence in order to improve our clinical practice in our patients. Thank you very much for your attention.